this is just my disclosure statement saying that I don't have any financial conflicts of interest. And this is just about me. I'm not going to go, I'll just introduce myself quickly. So my name is Lisa Morad-McCoy, and I'm a social worker by training. I have an LCSW, which is a licensed clinical social worker. Some of you may be familiar. I work at the University of New Mexico in Albuquerque, New Mexico, and I do a mixture of clinical work and supervision. We have a program in New Mexico that allows for LMSW, so licensed master social workers, to get supervision and then become fully licensed, and we do telesupervision so that we can improve access to supervision in rural and frontier communities. So that's a big part of what I do. I also do some clinical work. One of the big pieces that I do is I do clinical work with kids and families in a school-based health center in Havasupai, Arizona, the Havasupai Reservation. And of course, that's also telehealth because you either have to go down by mule or hike down. So, but it's a wonderful part of my job, and I get to interact with that community. And I'll be talking a little bit about that today. So you can go on to the next slide. Okay, so our objectives today, and again, I'm really sorry for the late start, so I may have to fly through a couple of these slides, but first we're going to talk about some statistics and red flags related to intimate partner violence. I use the word intimate partner violence. That's a bit of a change in language from what it used to be. It used to be domestic violence, but intimate partner violence is any violence that happens to someone that you've been that a person has been in a romantic partnership with, and we'll go over that a bit later. We're going to talk about some of the dynamics of screening for intimate partner violence for those of you who are in medical settings. And some of the dynamics that happen with intimate partner violence that can really be difficult when it comes to either just having a relationship with someone or treating them in a medical setting. And then we're going to go over some state, national, and local resources for IPV, as well as doing some safety planning, looking at some safety planning resources. Okay, next slide. So who is likely to experience IPV? We're going to look at that first. We can go to the next slide. So intimate partner violence is unfortunately very common, and it affects 1 in 4 women in their lifetime and 1 in 10 men in their lifetime. And, you know, I always say that statistics around issues like intimate partner violence are low because there's a lot of shame in reporting violence when you're in a relationship that's violent with anyone. There's a lot of shame that the survivor can have related to it. And so I think some of these statistics are low, but these are what are reported. So basically that's 20 people per minute have some form of intimate partner violence occur. And of course, as you can imagine, some of the risk factors are going to include pregnancy, low SES, any minority. It says here racial or ethnic minority, but really anybody who isn't in part of the dominant culture has a higher risk. I'm not going to say a much higher risk, but definitely a higher risk of IPV. And the reason why I say it like that is because I think that, and the statistics show that intimate partner violence is really, anybody can experience it. It doesn't, at the end of the day, it doesn't matter what ethnicity, race you are. Of course, that puts you at a slightly higher risk, but I just want especially for medical providers, somebody who comes in who may not fit the bill, it's still important to ask the questions about intimate partner violence, and we will go over that a little bit later. And also, if you're in a rural area, that can increase your likelihood, mostly because you're more isolated and don't have as much support in those communities. Okay, next slide. Okay, so this breaks it down in terms of women. So women are more at risk of intimate partner violence, and people who identify as women. It's a little higher among Black women and Native American women, but this is again to say that these statistics are likely low. You know, each of these groups are probably a little higher, but the reason why I put this slide in here is to show how really pervasive intimate partner violence is for people who identify as women. Can everybody hear me okay? Okay, next slide. So this is just a website. If you get some time, and I sent the PDF of these slides to China, so you should have access to it. This is just a slide that shows by state the statistics of intimate partner violence. And I know this is a national conference, but I was happy to see that New Mexico is not super high on the list. I mean, we're not super low either, but you know, New Mexico is one of those states that tends to have terrible statistics all the way around. So it's just interesting to see how things vary in terms of the state that you live in. Okay, next slide. Okay, so now we're going to hone in on some high-risk populations. Next slide. So these aren't all the high-risk populations out there. Certainly, this is not an inclusive list, but these are sort of 4 big ones that are important to keep an eye on in your practice, in your lives. If if you're attending this because you have family members or are in the health or behavioral health related field. Anybody who is LGBTQ, people with disabilities, both physical and cognitive disabilities, undocumented people, and seniors are going to be higher risk. And I'll explain some of that in the next couple slides. But, again, I want to stress that intimate partner violence is not something that is just for minorities. And the people who get missed in terms of intimate partner violence are people who don't look like the profile, but we want to make sure that we're always aware that this could be affecting anybody. Okay, so next slide. Okay, so first we're going to start with people with disabilities. So there, people with either physical or cognitive disabilities are going to be more at risk for intimate partner violence. And the reason makes sense. If you're physically more vulnerable and you can't move quickly, or you are more dependent on someone for mobility purposes, that leaves you vulnerable to emotional, physical, financial abuse. And for cognitive delays, that leaves you vulnerable to intimate partner violence because if you have a cognitive delay, you may not be aware enough to realize the red flags. Like if you're in a relationship with someone, you may not completely understand that the red flags that are happening are because this relationship could end up being more abusive in the future. And that's also cause for a lot of shame for people because they feel when it comes out as intimate partner violence, or they feel like they have to disclose it, they're more likely not to disclose because they feel a lot of shame around it. Okay, next slide. Okay, so seniors are sort of similar to people with disabilities in that they may have mobility issues. They also may have cognitive issues that are limiting them. And for those reasons, they're going to have more vulnerability to intimate partner violence. And I have to say, anytime you are dependent physically or mentally on somebody providing care for you, that leaves you in a very vulnerable position. You know, we want to think that most people who are caretaking are good and are doing it for the right reasons, but unfortunately that's not always the case. And also caregivers can also get, you know, suffer from compassion fatigue themselves, and so they can be a good caregiver up to a point, and then they start becoming more emotionally abusive and physically abusive because they are struggling as a caregiver. And that doesn't make it an excuse, or it doesn't make it right, but that's a dynamic that can happen with seniors. And one of the things that we're seeing a lot now, and I'm sure you've heard of this, is that seniors are suffering from financial exploitation. It's very common for people like telemarketers to call up and get seniors to give them access to their bank accounts. That not only happens with telemarketers, but it can happen with family as well. Family take advantage of seniors' difficulty with memory, difficulty with getting around, difficulty with understanding their financial status. And so that's actually really common and also a big source of shame for seniors. So they probably are going to feel very, very hesitant to disclose it. Okay, next slide. So Native communities are another population that I want to highlight, partly because I work with this population, also because this is an IHS conference, and so we really do have a lot of compassion for Native communities. And the thing about Native communities to understand and remember, and I'm sure most of you know this, is that historical trauma is a dynamic that we really have to hold at the forefront of our minds when we're working in Native communities. Historical trauma includes loss of sacred lands, forced assimilation, and family ruptures. And so one example is boarding schools that were created in order to make Native youth assimilate. That is only one of so many examples of oppression in Native communities. And I just want to say that I'm not Native, and I don't want to presume that I know all of the dynamics that occur around this. But we want to make sure that we understand dynamics of historical trauma. And I actually work, one of my colleagues, her name is Maria Yellow Horse Braveheart. She does a lot of work with IHS, so many of you may have already run across her or know her work. But she does wonderful work and research on historical trauma in Native communities. And if you Google her, look her up, you'll be able to find a lot of work around Native communities and historical trauma. And part of that historical trauma, so what does it have to do with intimate partner violence? If you're born into a population that suffers from historical trauma, you already have layers of trauma hardwired into your brain and into your system. And it makes you much more vulnerable to it, and also see it as normal. So you're born into this community where intimate partner violence could be seen as something that is relatively normal and accepted both by people in your community and people outside of your community. So I could talk for, this one slide could be an hour-long training, but I encourage you, if you haven't already, to do more research on this part of it. Okay, next slide. So impact on kids. I work in a clinic that does work with kids who have experienced complex trauma. And what we mean by complex trauma is when children are born into families where there has been systematic oppression in terms of intergenerational poverty and generational substance use. And so these kids, again, are born into families where they start to think that chaos and crisis is normal. And then they end up inadvertently getting into violent relationships themselves, and the pattern keeps going. And what we also know about kids who witness intimate partner violence is that some of their symptoms can look even more chaotic and at times worse than kids who've been physically abused themselves. And that stands to reason because it's human nature to have more difficulty watching a loved one be abused than being abused ourselves. That's a dynamic of human nature. And so kids who watch their parents, caregivers be abused have a lot of behavioral problems, a lot of aggression, depression, anxiety, hypervigilance. Hypervigilance is when they're just jumpy and are worried about their environment. When they hear a loud bang or are startled, they startle very easily. So we want to watch for that in kids and never want to minimize the impact of being violent for children. Okay, next slide. Okay, so now we're going to talk about some red flags. So what are some things to look out for when we are in some form of a relationship with someone, even if it's a working relationship, if you're a medical provider or a family member? Okay, next slide. Okay, so people can present with red flags. So say you are a behavioral health professional in your office or a medical professional, and somebody has injuries, for example, but they're telling you a story that doesn't quite match up with the injury that you're seeing. Or they're having behaviors, for example, extreme anxiety in the moment when nothing is really happening to make them anxious. That can be a red flag of IPV. And so the first thing you do is just notice it and keep it in the back of your mind. You don't have to jump on it right there, right then, but just notice that it's happening. Okay, next slide. So what we see, unexplained suspicious injury considerations. We see that injury isn't consistent with their explanation, just like I said. And if you're a medical provider, you may even see old injuries that are there along with a new injury that they're not telling you about. It's always important to ask about an injury, especially if you are a behavioral health or physical, a physician or a nurse practitioner. And when I say that, sometimes behavioral health professionals are nervous about asking about a physical injury. I believe that it's very important and it's part of our role. If you see somebody who has a bruise or something and you've already had a suspicion of intimate partner violence, but nothing's been disclosed, it's okay to ask what happened there, and just see what they say. Again, you don't have to, if you're a behavioral health professional and you don't feel comfortable, you don't have to challenge them in that moment. But again, notice. And eventually, you may have enough data to say, I'm worried about the fact that you're coming in with bruises, and it feels like it's not matching up to what's really going on. And you can say that once you've developed trust with the person in a behavioral health relationship. In medical, it's a little different. I'm not a doctor. I think you have a little more leverage in terms of being able to educate and say, you have an injury that's really old, and to talk to the person in front of you about it. Okay, next slide. Okay, so these are symptoms with really no visible injury, and these can be symptoms of a lot of different things. So it can be difficult to parcel out. But again, these are just ways to hold it in the back of your mind. So one thing that I think gets missed often is chronic pain. People who have been abused in some way or another, either if it's past abuse or present abuse, tend to present with a lot of chronic pain over a lifetime. And they tend to either be very hypervigilant about getting care, and they get care for every single little problem that they have, or they avoid care altogether. We tend to see the gamut when it comes to chronic pain. So it's not like you can say, oh, this person has chronic pain, they must be suffering from abuse. But it's one of those red flags that you want to keep in the back of your mind. And what we also see is that somebody might engage really well in behavioral health or medical health, and they might be doing really well, but once the medical professional or the behavioral health professional hones in and starts asking questions, they stop coming to treatment, and they tend to be non-compliant after a period of time. You see mental illness, anxiety, depression. You can see sort of alternating anxiety and depression, insomnia, trouble sleeping, or you can see the reverse, which is sleeping too much as sort of a way to escape their reality. And you can see some intense reactions to medical procedures that may not, that really aren't, typically difficult for people, like maybe a shot, for example, or a blood draw might be extreme. Those are difficult for some people, but they may take on something that is much a higher level of stress for people than usual. And then they can have fear of conscious sedation, because what is that? When you're consciously sedated, you're out of control, and so they feel a lack of control. Okay, next slide. I'm running out of time. So I'm going to sort of go quickly by these screening tools. Next slide. Because I think the other parts of this presentation have some just more tangible information. But I would say the most important thing about dynamics of intimate partner violence are to ask about it. And on this slide, I actually have IPV and SA. When I say SA, I mean sexual assault, but really sexual assault is part of intimate partner violence. You want to ask questions directly. Try not to beat around the bush. Document as much as you can about it. and make sure that the person, when you ask them, is in private. Okay, because if they have somebody with them, you don't know. That person could be the person that's abusing them, and they're not going to say anything. Okay, next slide. So these are 2 screening tools that you're welcome to look up if you want to. All of these are available for use by medical professionals. So I'll let you look those up on your own. Next slide. Same with this one, although the relationship chart, the thing that I do want to highlight about this one is that it has pictures, which can be a wonderful tool when people don't, especially if somebody has cognitive delays. It's a lot easier to understand what the provider is talking about when there's a picture. Next slide. This is another tool that you can use. I'm going to go ahead and let you look that up on your own. Humiliation, afraid, rape, and kick. They do that for a little mnemonic for you. Okay, next slide. Okay, so now we're going to get into some of the dynamics of IPV. Next slide. So many of you probably have seen the power and control wheel. That is a very basic educational tool for anybody who's going into working with IPV or people who are experiencing IPV. And what it displays is that intimate partner violence is a pattern. And it usually takes on some form of a pattern where there is this cycle of love and, partnership and cherishing, and, the abuser just professes love to the person. And then there's a period of tension that escalates and escalates into violence. And it can be any of these types of violence: coercion and threats, intimidation, emotional abuse, isolation, minimizing, denial and blame, using kids to abuse as like a form of emotional abuse, and economic abuse. And so this period of tension escalates into actual abuse, into a period of intense abuse. And then there's a period of the abuser feeling very guilty and saying that they're sorry, that they're never going to do it again, that they're going to change. And then this cycle tends to start up all over again. Now, this is not always the case, but it is very much a regular dynamic that happens. Okay, next slide, please. So why do survivors stay? And this is a question that so many people have. And, the answer is complicated. And so the answer lies in dynamics of power and control. If you've been abused by someone all your life, or even a chunk of time out of your life, and it has robbed you of your self-esteem, of your sense of self and who you are, because isolation is very prevalent in these relationships, where the abuser will sort of pluck the survivor victim right out of their support network. If all of those things are taken from you, then you are more likely to stay in a relationship that is abusive. Also, the most dangerous time for victims is when they try to leave the relationship, because 9 times out of 10, the abuser can sense it and knows and understands, and that's when the abuser becomes the most vulnerable and the most afraid and starts acting out on their own. And that could mean violence or ultimately killing the victim. Okay, next. So some more emotional dynamics. The survivor could be in denial of danger. Why? Because this could be a way that the survivor or I'm using the word survivor and victim interchangeably, but it could be that the survivor has lived in violent relationships their whole life. And so really this isn't all that abnormal for them. They may not have a support system. They're most at risk, like I just said, when they start to try to leave the relationship. They have fears of losing custody of their children, because one of the primary ways an abuser will use the kids to abuse is to say, well, I'm just going to say that you're an unfit caregiver, or you're not, they're not going to let you keep the kids because you don't have any money, or something like that. The survivor then believes that and stays in the relationship. And again, when you are a minority, you tend to be more vulnerable because of different dynamics. And this one dynamic that I didn't go over is if you are LGBTQ, you may not be out to your community, and so disclosing intimate partner violence may force you to do that before you're ready, and so you may delay it until you can't anymore. Okay, next slide. So what's the impact on mental health? A lot of this stands to reason. Depression, post-traumatic stress disorder, I'll talk about that in just a minute. Low self-esteem, and that low self-esteem drives this feeling that I have to stay because I don't have anything better, because I am not enough, and I am not, I'm not deserving of a good relationship or a supportive relationship in my life. People can become suicidal, and of course have a lot of anxiety. Let me talk a little bit about post-traumatic stress disorder. So post-traumatic stress disorder is a DSM-5 diagnosis, and basically the symptoms of it are extreme stress reaction related to a traumatic event or a series of traumatic events. Not all intimate partner violence will result in PTSD. There's a lot of different ways that it can manifest. It could be a more acute stress reaction where once they get out of the relationship, they do okay. There's others who come out of the relationship and aren't okay for years, and that has more of a PTSD flavor to it. I just don't want everybody to put all the IPV symptoms in a PTSD bucket. And so we just want to make sure that we understand that mental health is so impacted by intimate partner violence, and that is a huge reason why people stay, because they feel like they don't have the ability to leave, either emotionally, financially, or physically. Okay, next slide. So emotional dynamics. So all of these emotional dynamics can happen and can lead to physical health issues. So this is just to say that our minds are connected to our bodies. And so when we are experiencing emotional distress, we are more likely to experience physical distress in the form of these issues. And this, again, isn't an inclusive list. So mental health impacts physical health. Okay, next slide. So what about the legal system? And the legal system is complicated when it comes to intimate partner violence, but I'm just going to try and scratch the surface here a little bit. Okay, next slide. So these are two, talking about restraining orders, these are two forms of a restraining, or this is one of two forms of a restraining order. So there's an ex parte restraining order and then a more permanent restraining order that we'll see on the next slide. The ex parte allows for victims to receive protection for 2 weeks until until there's an actual trial for the abuse, for the intimate partner violence. So let's go to the next slide and I'll show you that. Okay, so the permanent restraining order is usually allowed for up to 2 years. And I'm showing you all of this is because there are processes to help victims with this. There, and it's important to know your state's laws around protective orders, because a lot of victims will say, well, a protective order doesn't work because it's just a piece of paper. But really, what can happen is if abuse does occur, then the abuser, if they have violated the protective order, is more likely to get some form of punishment via prison or jail. So, I know it can feel like if you're in the field, like you're banging your head against the wall with protective orders, but I do think they're worth understanding and knowing about. Okay, next slide. So statute of limitations, I don't want to get too far into the weeds on this. The thing to understand about statute of limitations is that a lot of people will say, well, I don't want to report because it was 10 years ago or it was 5 years ago. And so they think that they can't report. Well, laws in different states are changing, and statutes of limitations are being done away with in several states. And so again, it's important to understand the laws so you can let a victim know, no, you have until, you don't, there is no limit on when you can report this, and it's okay. And the reason why that's in effect is to tell victims, we believe you, and when you talk about it, it doesn't matter how long ago this happened. We're still going to believe you and take you seriously. Okay, next slide. Let's skip this one just because it's some of the same information. So safety planning and resources. Next slide. So a safety plan is it's a plan to help a victim understand their safety and to create safety both within the home and out of the home. And this quote, this down here says an opportunity for the abused woman to gain information in order to strategize her responses. This is not just for women, okay? I want to make sure that gender is not, because men and people who identify as women, this touches everybody. So next slide. So we want to get a good history for safety planning. Okay, let's go to, I just want to show one of the resources for safety planning. If we can just click through, and I'll tell you when to stop. Okay, stop here at the same. Yeah. Okay, so let me talk about, I'm just going to kind of wrap up because we don't have time for the rest of my slides. I'm assuming we don't have time, right? It's already 2:15.
We can go until 2:30, Lisa.
Oh, I can?
Yep, that's fine.
Oh, okay. All right, let's back up to the same slide. One more. Okay, stop there. Let's go to the next one right after that. Okay, one more. Okay. All right. So we'll talk more about safety planning. I didn't know I could go until 2:30. Great, thank you. Let me just ask before I keep moving, because I don't want to get to the end without allowing any time for, are there any questions up to this point at all? Okay. All right. Well, you're welcome to put questions in the chat, and I'll answer them as I can. I can't really see the chat that well, but I'll do my best. Okay. So safety planning strategies and resources. These are just ideas to help the victim with safety planning if you're in a position to do that. Just kind of, prompt them and say, well, we're not saying you have to leave tomorrow, but let's have some things ready so that you have the opportunity to leave if you can and you're feeling like you can. And so keeping cash on hand, having supplies for kids, having contact information, just kind of having a getaway resource file or list so that getting away isn't as difficult. Next slide. So a little bit about medical treatment. I used to work for Para los Niños, which is a medical team here at the University of New Mexico, which does medical exams for kids and teenagers after they have been through sexual abuse or sexual assault. And I would say medical treatment is so important for people to feel empowered and to feel physically well after an incident of violence. And it's not just for injury documentation. So if you have a victim in front of you, in whatever capacity you are, you can educate them that it is medical, because a lot of people think, oh, well, if I go get treated for something or I seek medical advice, they're just going to document my injuries and I'm going to be forced to talk about this and disclose and go to court. That's not the case. So in the case of sexual assault, for example, the evidence collection kit is kept on file until the victim is ready. Now, that's not in the case. It's different for children, okay? Don't lump children into this. That's a whole different ball of wax. But for adults, they have choice in the matter, and they can decide when they want the evidence collection kit to be used. Okay, next slide. Okay, next slide. This is the same. And so New Mexico and many other states have a sexual assault nurse examiner's unit. Okay, so the name is a little misleading. Most SANE units, they used to just do injury documentation for sexual assault. Now more and more of them are doing it for all IPV, so all intimate partner violence, not just sexual violence. So that's important to know because that's been a big change over, I think, the last 10 years. And so New Mexico has a SANE unit. Most states have a SANE unit available, and they are trained in medical documentation, doing medical exams of victims, which is so important because they do it in a way that feels empowering and feels not re-traumatizing to the victim. And so when and if you can, if you're a provider or even a family member, see if you can find a SANE unit if somebody's ready to seek medical treatment, because they're going to get the best care there, especially if the abuse has happened in the last 5 days. But even if it's happened later than that, you can always call a SANE unit for resources for medical providers who are intimate partner violence friendly and who, you know, really understand what they're doing and the dynamics that they're being faced with. Okay, next slide. So this slide is basically to say that if we can get victims into some form of treatment and advocacy services, it doesn't even really matter what kind, they do better. So when people are supported after they have been through an abusive relationship or even during, their outcome is better. I think, you know, as a behavioral health professional, I think group therapy is some of the best therapy that is out there, just supportive group therapy for victims of IPV, because what happens is they get to learn from other people's stories, and they also get to realize that they're not alone. I did several groups for adolescents at Para los Niños, and I also did domestic violence support groups for victims and perpetrators early in my career. And I feel like people got better when they went to group, even more so than individual, because there's just something so powerful about your peers, about people that, you know, of any age going through what you've been through and seeing the outcome. And so there's this mentorship that happens, and people's self-esteem tends to really heighten when they're doing group therapy. Okay, next slide. You know, this basically says the same thing. I really think personally, I think closed groups are the best thing, where people come to group and they see the same people every week. That's not always possible, and it's not always sustainable, but I think that's the best way to help somebody who has been through intimate partner violence. But even if they can go to an open group, which means that different people are going to be there potentially every time, I still think that that's really helpful. And there's so many evidence-based practices in individual treatment for some of the symptoms of intimate partner violence and PTSD if somebody is going through that. There's trauma, there is cognitive, trauma-focused cognitive behavioral therapy, which can be really helpful. So as a provider, just know that there are treatments out there and that people can get help. Okay, next slide. Okay, so let's talk a little bit about some national resources. I have the websites here for RAIN, which is specifically sexual assault, and then for the National Domestic Violence Hotlines. All of these national hotlines will point you to local resources. So don't be shy to use them, and they can be really helpful. And again, you'll get a copy of these slides, I'm assuming. You'll get the PDF. Next slide. This is for child abuse, some resources for child abuse. There's national resources on here. I really just encourage you, especially if you're a medical or behavioral health provider, don't minimize kids witnessing domestic violence. You're in a position to really change a child's life if you can help them understand and get help for this early. It's not always easy, but if you can. Okay, next slide. So these are Indian Health Services resources, which many of you may already be familiar with, but IHS has wonderful Native-specific resources, which are great, and they're all on the website. So take a look at those if you're working with Native communities. Next slide. And okay, I made it. So we have 3 minutes for questions.
If you guys are nervous to come off of mute, that is a-okay. You can always type your questions in the chat box as well too. And if we do run out of time for questions, you can go ahead and send an email to me or to China, and I put our emails in the chat box, and then we can pass them along to Lisa.
Thank you, Stacy. I appreciate it. Yeah, and if any of you have any questions, China, you can always give them my email. I don't know if I put it on the on the PDF now that I'm thinking about it, but you can always forward. I'm giving permission to China to give any of you my email address if you have any questions or want to talk about this further.
Sounds good. Thank you, Lisa.
And again, I just apologize for my lateness and time difference issue.
No worries at all. I promise. It happens to the best of us. It does. I did it yesterday, and I was so late to a meeting. I thought it was a different time. Don't even worry about it.
Okay,
I don't see any questions coming in. And if that's the case, I will go ahead and stop our recording.